Good afternoon, everyone. I am Dr. Ramprasad. Uh, Hailing from a small tier 2 city, as Modi sir told, as Vadodara, it's Guntur in Andhra Pradesh. First, I would like to thank Merrill for providing me this opportunity and extend my thanks to Dr. Rajesh Malhotra as well, who was our teacher at All India Institute. And this all teaching made us stand as here and excel in our private practice. So let us see what literature tells about hybrid THR. You mean what hybrid THR is? It's basically uncemented acetabulum and a cemented femoral stem. So you might think that this is much more of inferior quality, but it's not so. The literature says a different thing. Okay, the cemented acetabular components might be of inferior results compared to its uncemented counterparts. So you go ahead with an uncemented acetabulum. But coming to the femoral side, if we see at the long-term results of cemented femoral stem, actually they are good at 20 years also, and they are not inferior to the uncemented counterparts. So I mean to say that I might be prejudiced, but still cemented femoral stems, they are working and they will work. They are here to stay. They are not to expire. So let's look at the indications. So wide femoral canals. This is, I think, a layman language. Everyone can understand, and they have undisputed indication. In DOR type C canals, where you perform your total hips in more than 60 or 70-year-old individuals, even Dr. Raju Sharma has performed his complex total hip. So he was using a cemented femoral stem. So definitely in DOR type C canals, it is my type 1 choice. And in rheumatoid patients, also, as in the morning, Dr. Rajesh Malhotra was telling that you need to have screws for your rheumatoid patients for acetabular socket. So as such, so in the same way, in rheumatoid, I would always keep a cemented femoral component as a backup in my armamentarium. So if you have previous failed surgeries such as failed PFN or DHS, intraoperatively, definitely after the neck cut, you might be seeing some malunion of the proximal femoral component such as retroversion of the proximal femoral canal. So you will be disarmed by the uncemented femoral stem, where you can't really control the limb length, you can't really control the anteversion. So in those cases also, the cemented femoral stem, I think that is the good choice. But you should be careful that the stem should be crossing the screw side, and you should be careful during cementing. And in failed cases of bipolars or AMPs, just as in this case, so if the loose bipolar or hemi component rotates in the femoral canal remodels to retroversion over time. So you should always be careful during surgery to recognize that point that femoral canal might be retroverted. You might be uh, uh, going ahead with the retroverted uncemented component, but that is going to reduce your combined anteversion and increase the risk of instability. So cemented femoral stems, they have an advantage so that you can control the version. And in difficult cases where you need to replicate the native biomechanics, as we have say in the lecture by Dr. Subhash, that you only uncemented femoral stems, they come with 132 or 135, and nowadays only they are coming up with this 127 high offset stems, but you can't really replicate in every case the same anteversion, limb length and offset. So with cemented components, you have already high offset 127 degree stem. So the upside is you don't need to depend on the stem size for your offset and limb length calculation. So you can have independent control over the offset and limb length, and which is independent of the stem size in cemented stems. So in young patients as well, if you are finding 20-year results with cemented femoral stems, considering these schemes which Modi ji and our Andhra Pradesh Chief Minister, so 80% of the patients we do and the surgeons over here in tier 2 cities, so I think we need to optimize the compromise. So we need to learn techniques for good cementing and extend the longevity as well. And in young patients, sometimes you see dysplastic hips. There you will be seeing the retroverted femoral canals. Either you should be using a longer stem or a cemented femoral component would be of choice. And sometimes you will face some unusual circumstances where you will be seeing a broken implant like this. Then I think instead of going for a big surgery, removing the cement, going for a longer stem, I think cement in cement revision would be a very better option for the patient as well as surgeon also. So I would like to conclude that old is gold, and still we listen to the retro classics and sometimes in a remixed version. So thank you for giving me this opportunity, sir. Sir, thank you, sir. Your lecture was too intimidating, sir. So a small lecture like this, I think it's too small.
May I ask you a question?
Yeah, thank you, sir. Yeah.
So, what would you recommend as the combination when you talk about a hybrid THR? Would it be an uncemented cup and a cemented stem, or would you suggest the other way around as well?
No, sir. I think going by the literature, uncemented cup and a cemented femoral stem.
So
that is
brings me to
hybrid.
the follow-up question. Why do you think that in the cup side doesn't seem to work very well in the cementation methodology, unlike the stem side, which seems to work very well? Why do you think is that?
That is, I think, more a philosophical question, sir. I think you are the best judge to answer that question rather than me.
You know how to counter very Okay, so what is right? Let me explain to you, gentlemen, why. The only reason the cement does not work all that well on the cup side is because of the anatomy and the technique that is associated with cement. A cement works, cement is a grout, it's not a glue. Acrylic bond cement is a grout. What's the difference between a grout and a glue? A grout is like it requires spaces where it can go in and lock itself. That's a grout. A glue is jo chipak sakta hai. So it absolutely polished surface can be stuck together if you have a glue, but it cannot be done so if it's a grout that you are using to bring them together. In other words, the acetabulum does not offer itself for high pressurization all that easily. In the past, there have been instruments developed to try and counter this issue. For example, the acetabular pressurization system, etc. But despite all the efforts, it can never match the amount of pressurization that you can achieve in a femoral stem in terms of the geometry and anatomy. And that is why acetabular cups cemented cups have a higher failure rate, and therefore the hybrid philosophy or approach is a good one to keep in mind. Do your acetabulum uncemented and go ahead and get your cemented stem, especially in certain type of osteoporotic bone where uncemented stem insertion is associated with a very high fracture rate. Any of you who want to understand this better should hear Ross Crawford from Australia. His lectures are there on the YouTube as well, I think. And you will understand this philosophy superbly as you do so. It's a good topic, you did a good job. Thank you.